Welcome to the Seizure Training for School Personnel online course. My name is Aisha Akhtar, and I am the Director of Education at the Epilepsy Foundation of Greater Chicago. This training is an introduction to basic seizure types you may see in the classroom. It will cover first aid and highlight the seizure action plan. Beginning July 1, 2020, this training will be mandatory for all school personnel as part of the Seizure Smart School Act. Let's start with defining seizures. A seizure is commonly referred to as an electrical storm in the brain, but what does that really mean? To help understand this further and how it affects the brain, it is helpful to think how cell phones work and apply that analogy to the brain. Cell phones use electrical signals to transmit information. If there are too many signals in an area, sometimes messages are blocked, delayed, or undelivered. In the brain, we have millions of neurons that are also transmitting electrical signals directing information from our brain to our body. If there are too many signals or the neurons crossfire, a seizure can occur. That seizure can cause a person to have a change in their movement, behavior, awareness, or senses. There are more than 20 types of seizures, and today I will focus on several common types you may see in the classroom. Seizure characteristics will be stereotypical. You are looking for like or similar symptoms every time. This means that when a student in your classroom presents a symptom, such as smelling oranges, as an example, he or she will always experience that symptom. This information should be provided on the seizure action plan. Seizures also have phases. The prodromal phase of a seizure can be hours before or days before a seizure actually begins. You may notice a change in a student's behavior. The aura is the first sign of a seizure, and it is like a gift because not everybody has that experience. Some students describe feeling funny, have a metallic taste, have a slight hand tremor, or have an altered sense of smell before a larger seizure starts. The ictus phase is what is actually happening during the seizure, and the post-ictal phase describes a person as they return back to baseline. Having one single seizure is not epilepsy, but rather it is a diagnosis of recurring, unprovoked seizures. The onset of epilepsy can occur at any age. For 30% of people living with epilepsy, there are 4 commonly known causes: traumatic brain injury, brain tumor, stroke, and brain infections, such as malaria. For 70%, the cause is unknown. Traumatic brain injury is rapidly becoming the fastest growing population of people developing epilepsy. Epilepsy is the 4th most common brain disorder. Worldwide, there are 65 million people living with active epilepsy. Active meaning the individual has had a seizure within the last 12 months. In the United States, there are 3.7 million people living with epilepsy. The lifetime risk of developing epilepsy is 1 in 26. And 1 in 10 people will have a single seizure in their lifetime. Epilepsy is considered a spectrum disorder because it affects many aspects of physical and mental health. Health issues such as depression, anxiety, fertility, and cognitive development are very common as epilepsy comorbidities. All seizures fall into one of 2 categories. A generalized seizure affects the entire brain at one time, and those symptoms include muscle convulsions, staring spells, spasms, and falls. Or a seizure can originate in one part of the brain, and that is called focal, also known as partial. Those symptoms depend on where the seizure originates. For example, the occipital lobe, which is responsible for vision, is an area in which a seizure can originate and can cause a person to have excessive or rapid eye blinking. The first seizure I will discuss is the generalized onset non-motor seizure. In 2017, the International League Against Epilepsy changed the names of all seizures to more accurately reflect the actual seizure activity. The first I will discuss used to be called the petit mal seizure, then the absence seizure. Now it is called a generalized onset with no motor symptoms. This is a quick seizure with a brief lapse of awareness and can last from 1 to 10 seconds. It looks like daydreaming or that the student doesn't want to pay attention in class. It can occur in clusters, and no first aid is necessary here. The second seizure I will discuss is probably what most people associate with epilepsy and seizures in general, but is not the most common. This used to be called the grand mal. and then it was called a tonic-clonic seizure, and now it is referred to as a generalized onset with motor symptoms seizure. This one begins with a hoarse cry or a moan, followed by a loss of consciousness and a fall to the ground, whether they are standing or sitting. The moan is simply air that is compressed from the diaphragm. The person is not in any pain at all. The first phase of this seizure is the tonic phase, and the arms and legs will stiffen. Some will stay in this phase, and others will go on to the clonic phase, which is the convulsive phase. Arms and legs and any other muscle will contract. Eyelids can open and close. There may be shallow breathing and drooling, and the combination creates foam at the mouth. It can be frightening to watch, but everything that happens to the person during the seizure is normal, and our job is to make sure the person is safe and to not interfere. This seizure lasts 1 to 3 minutes, and beyond 5 minutes, it becomes a medical emergency, which is called status epilepticus. Rescue medication is needed to stop a seizure at that time and will be discussed later in this course. The following are 2 other generalized seizures you may see in the classroom. The first is the juvenile myoclonic seizure. Here you may see sudden, brief muscle jerks, like a shoulder shrug or a muscle spasm. No first aid is necessary here. Second is atonic or drop attack seizures. This is a quick seizure involving a sudden loss of consciousness. The person will regain consciousness within a minute and resume whatever activity they were doing. Some kids may wear a helmet as protection. Focal seizures, which used to be referred as partial, can present with or without motor symptoms and with or without awareness. A focal seizure originates in one part of the brain, and depending upon where it originates, the symptoms will vary. In a focal aware seizure, a person is awake, alert, and aware that they are having a seizure. For example, a person may wring the arm, but is not able to control that behavior because the way the motor cortex is controlling that action. The student may also have non-motor symptoms they cannot explain, such as a sudden sense of fear or an unexplained feeling in the stomach. This is a quick seizure with a quick recovery, and no first aid is necessary here. Focal seizures are also known as auras, and some students may experience these symptoms and know that a bigger seizure may begin soon. The last seizure I will discuss used to be called a complex partial seizure and is more common in adults rather than students. It is now referred to as a focal impaired awareness seizure. In this type, the person is not aware that they are having a seizure. It begins with a blank, dazed stare, then he or she goes into automatisms or repetitive purposeless movements. It may look to bystanders that a person is confused, has behavioral issues, or is under the influence of drugs. In the classroom setting, we often hear about students who wander or try to climb onto desks. Remember that with the altered awareness, the person having the seizure will have no control of their seizure activity. First aid for a convulsive seizure is very intuitive. Your main job is to ensure the student is safe. You can do that by turning the student on his or her side, protecting their head, and remove hazards out of the way. Track the time as soon as the seizure begins and never put anything in a person's mouth. The first aid for a focal onset with impaired awareness seizure, also known as a complex partial seizure, is also straightforward. Please make sure that you do not restrain or hold back the student if they are wandering. You can protect them by blocking hazards such as doorways or stairs. Remember to track the time as well. 5 minutes becomes a medical emergency. In the event you have a student having a convulsive seizure in a wheelchair, please secure the wheels, fasten the belt, and allow them to have the seizure in the chair. Protect and support their head, and you can remove them after the seizure has ended. Finally, it is important to know and follow the seizure action plan for appropriate emergency protocol. Most seizures will not be emergencies. However, there will be some instances in which you will need to call 911. A first-time seizure, if a student had more seizures than usual or a different type of seizure, if the student got injured during the seizure, if a convulsive seizure lasted more than 5 minutes, if the seizure ends and another one begins right away, and finally, if the seizure action plan instructs you to call 911. Once a person is on medication, they usually have very good control of their seizures. Most are aware of triggers, but many people continue to have seizures out of the blue. We call these breakthrough seizures. The most common trigger for a breakthrough seizure for up to 50% of people living with epilepsy is missing a dose of medication, or if the medication is taken late. Here are some commonly known triggers: overheating, stress, anxiety, lack of sleep, poor diet, and hormonal changes. The first course of action for people living with epilepsy is anti-seizure medication. There are over 20 types of anti-seizure medication, and some people may take medication once or twice a day. However, this treatment only works for 70% of people. Be sure to know if there are any side effects from the medication your students are taking. Sometimes the unwanted side effects of medication preclude people from taking it in the first place. Common side effects are forgetfulness, tingling in the fingers, weight gain, and weight loss. Epidiolex is an oral solution, recently FDA approved for the treatment of severe forms of epilepsy. It is a synthetic form of CBD and does not have any THC elements. For 30% of people living with epilepsy, medication does not work. Here are some other options. The vagus nerve stimulator is surgically implanted into the left chest and it's connected to the vagus nerve. Its job is to send regularly programmed pulses to the brain to regulate brain waves. A manually stimulating VNS will require the student or someone else to wave the magnetic band over the VNS to abort the oncoming seizure or reduce the severity of it. There is also an auto-stimulating option that is connected to heart rate and needs no magnetic band to be waved over the generator. The responsive neurostimulator, RNS, is a little more invasive and is surgically implanted under the skull, and the electrodes are inserted right at the seizure site. The RNS works as a call and response to detect and abort seizures immediately. The device continuously works 24 hours a day. Surgery resection, or laser ablation, is also an option if the person is a candidate. Laser ablation takes about 10 minutes and can be very effective. Finally, dietary therapy is a growing option, especially for families of younger children. The ketogenic diet has been found to work well in difficult-to-treat seizures by eliminating all sugar and maintaining a high fat and protein content. As always, one should seek the best option for seizure control after consulting all options with their physician. Sometimes a convulsive seizure will become an emergency when it lasts longer than 5 minutes. If this occurs, you may need to provide a rescue medication. The gold standard for this would be an IV of Valium. Since we are not able to provide an IV, the next best rescue medication is Diastat, which is a gel form of Valium and is administered rectally. It is covered under the Good Samaritan Act of Illinois, takes 15 seconds to administer, and is caregiver approved. It is not a preferred treatment of option, given the possibility of embarrassment, but is very effective. In May 2019, the FDA approved a long-awaited alternative to the rectal gel in the form of a nasal spray called Nasolam, which is the drug midazolam. The efficacy is similar to the rectal gel, but the method of administration is much easier. Remember, these are rescue medications to be administered in an emergency situation for a seizure that has gone beyond 5 minutes. Please refer to the seizure action plan to determine at what time during the seizure the delegated care aide would administer the rescue medication. In order to best be prepared for a seizure of any type in your classroom, we strongly recommend that a seizure action plan be completed by the family and submitted to the school. It should highlight all the seizure information, including symptoms and time to call for an emergency. Contact info should be listed, and it should be signed by the treating physician. A copy of this form should follow the student wherever he or she goes. This form is available via download from our website. Now that you are prepared with first aid and an action plan, this form will be most useful in tracking seizures and observing patterns and triggers, if any. Many families find this to be one of the most useful tools when visiting their epileptologist, who is a neurologist that has a specialty in epilepsy. Some parents and teachers keep journals to share with each other. The best method to inform the parent about the child's seizures should be the most consistent.